Thank you, Brian. We're going to start with a little fun film before I begin my presentation.
In a world of recovery audit contracting, with the U.S. healthcare system and billions of dollars at stake, there are as many players as there are viewpoints. Kinda like school. Meet the providers.
Touchdown!
And the contractors.
Super genius!
Claims processors.
Can we agree on something?
CMS, HHS.
Can you believe this?
Medicare and Medicaid recipients.
Like, wow.
Did we mention taxpayers?
Now what do you want?
But today, let's focus only on two groups, providers and contractors. It's not telling tales out of school to say that these groups sometimes don't get along.
Nerd.
Excuse me.
Hold on there. Did we just see agreement? In the School of RAC, everyone can learn.
So that's my topic for today. Raymond Carter asked me to speak with you all about the contractor's perspective. Now, before my School of RAC students throw spitballs at me, I want to tell you a little bit about HMS, and then we'll get into our agenda. HMS actually started serving government healthcare programs in 1985. Our main service is coordination of benefits, primarily for the Medicaid program, and today we coordinate benefits for over 90% of the Medicaid recipients. What we do is identify the primary insurer and give that information to both providers and Medicaid programs and health plans so that they can coordinate properly. In 2007, we moved into adding other services to our product line in compliance, eligibility, and reviews. And today, we work for over 47 Medicaid programs, Medicare, the VA, the DoD, and several health plans. So as I said, today we are going to focus on the contractor's perspective, and as Brian mentioned, it's fair to say that HMS has a pretty broad and deep perspective on RAC. Today, HMS is the Medicaid RAC in 28 states, and our wholly owned subsidiary, HDI, is the Medicare RAC for Region D. So with that, let's take a look at my agenda. I'm going to start with just a brief RAC history, go into some updates on both the Medicare and Medicaid contracts, talk about our stakeholders and areas of common ground, and then end with a few recommendations from the contractor's perspective. So here's the RAC history timeline. You all know the Medicare RAC demonstration project started in 2005, focused on 3 states, California, New York, and Florida. In 2006, it was mandated as a national program under the Tax Relief and Healthcare Act. And then in 2008, the national program rolled out. 4 regions encompassed all states and U.S. territories, and 4 contractors were hired. In 2010, the Affordable Care Act actually expanded the RAC program to Medicaid and Medicare Part C and D. And then earlier this year, we saw the reprocurement of the Medicare RAC regions released. Now, it was subsequently pulled back and has yet to be re-released, but we'll talk about that more in a moment. Before we go into the Medicare RAC, which I know that most of you work with or in some capacity, I wanted to just give you an update on what's happening with Medicaid RAC, because since this may also affect your businesses. Here is a chart of all of the Medicaid RAC activity by state. You can see that most states have a contractor in place. Some are already operational, have implemented, and there's a variety of different contractors. This information is updated regularly on Medicaid-RAC.com. So if you want to know who the contractor is for your particular state or location, you can go to that site and get the information. Regarding the Medicaid RAC's operations, what I wanted to let you know, now that we have been operating several of these Medicaid RAC contracts is that every single Medicaid RAC is unique. Just like the Medicaid programs themselves, with different reimbursement rules, different benefit plans, different beneficiary demographics, the Medicaid RAC programs are also turning out to be unique in their own way in terms of what types of claims the states want to pursue, what the appeal process would be, and a variety of other variables. There's not two that look alike. So if you are impacted by this, it helps to understand what your particular state is doing. Now, one other interesting, notable fact about the Medicaid RACs is that the managed care population is not required to be audited. So under CMS guidance, they said the states do not have to audit managed care claims under their RACs. And given that Medicaid is now about 70% managed care versus fee-for-service, you can see how that impacts how the programs would be different by state. Other significant updates for the Medicaid RAC program is that because the states already had many audit and review programs in place before the Medicaid RAC, there's significant coordination required. States, OAG offices, the Office of Inspector Generals, the Medicaid fraud control units, they all had existing review programs in place. So now the RACs come along and they have to be very careful about not overlapping with all of these other entities that are doing some type of review. And last, I wanted to mention that in recent months, CMS has required states to report on their RAC activity. So the Medicaid RAC reports now have to have what types of reviews are in process, what types of claims and providers are going to be examined, and the results of those. So you should be seeing public reports on those soon. Let's move on to Medicare RAC. So as I mentioned, the reprocurement of the original 4 RAC regions was released earlier this year. It was protested, pulled back, and CMS decided to do a voluntary corrective action. And it seems like Medicare RAC news changes daily, and this is an example of that. Since we turned in these slides to the conference, this information has also changed. It looks like the procurement, which was expected this fall and this month, will probably be pushed out to next year. So I'll tell you about the implications of that, but that we don't expect it to see it within this month now. Other changes that were made to the procurement is a national DME RAC contract was added. So one new vendor will be hired to handle all DME claims. And of course, the 4 other regions will handle only Part A and B claims. And the current RAC contracts with the 4 vendors have been extended through December 2005. Now, albeit a very limited scope, most of this extension was to make sure all of the appeals that are in place will be processed appropriately through the end of 2015. But again, these contracts were extended. I wanted to just make sure you were aware that the regions were also realigned. So the 4 original RAC regions were made equal in terms of claims expenditures. So you will see that some of the regions had, like Region D out in the yellow there, has added Pennsylvania and New Jersey, which seems odd, but it's to equal out the expenditures by region. Okay. So I think we're all up to speed on what's happening with these Medicaid and Medicare RAC contracts. Now let's get to meet the stakeholders. And as we all know, there are many stakeholders for RAC. It's not only the providers and the contractors and CMS. Congress is very interested in this program. Medicare beneficiaries are interested in this program. Seems like everyone wants a certain outcome. Today, though, since I was asked to focus on the contract perspectives, I'm going to keep my comments mostly focused on them, but I think to have a proper balance, we should also have some discussion about the provider's perspective. And here I have from my School of RAC the providers who have to block and tackle. So they're in my jock group, and my geeky data type contractors are in my nerd group, present company excluded, of course. So let's go on to the provider perspective. So as a contractor, it's interesting because we really do keep track and try to have as much dialogue as possible with providers to understand what their perspective is on the contracts and to make these contracts work better for everyone. Certainly, we know that these are administrative and cost burdens. Personnel need to be trained on RAC processes. There's still an enormous amount of paper being processed to execute these contracts. As I mentioned, there are many auditors, not only RACs out there auditing particularly hospitals, and that can also take a lot of time and cost for providers. It is a question whether clinical decisions should be questioned, and does that ultimately impact care? So that's been an outstanding question, I think, since the demonstration project started a long time ago. The appeals process, I think that everybody would agree there could be improvements there. I know that there are currently appeals in the ALJ process that are past the 90-day timeline, and that certainly causes a lot of hardship for all the stakeholders involved. I think the only other thing I would say here that's important is the contingency fee has been called into question by providers and others, in that if a contractor is paid by contingency fee, which of course means that they only get paid fees based on a percentage of any corrections they're responsible for, does that promote assertive behavior or behavior that is not appropriate for this line of auditing? So that's a question mark, and I think that's a good segue to contractors. So what does the contingency fee mean to contractors? Well, essentially, it means that for more than a year, for most contracts, we have to operate these contracts without a dollar of any fee coming in. So if you can imagine, we have to hire very qualified staff, often clinicians, train them, get them up and running and working for many, many months before they even find a correction and process a correction. The technology requirement for these contracts is very high. The investment to do the workflow systems, the algorithms and edit development, the processing for the recoveries is also quite a large technological investment. So you have contractors who may be working, as I said, for over a year before they even see a dollar of revenue. So what might that mean? It might mean that the pool of contractors will be restricted because few companies could manage that cash flow of not having any revenue for over a year on a certain contract, and that's very costly to operate. I think the other thing is it may drive contractors to have to look for real high dollar claims to make sure that they meet minimum operating costs. Other contractors' perspective, particularly on the state side with Medicaid RAC, data gaps are very prevalent. So state budgets have been constrained for many years now, and IT resources are the first to get cut. And what that means is that when a contract like the RAC has to operate, getting good data is step one, and without that, the contracts can't even operate or be effective. So with antiquated MMIS claims processing systems and lack of IT resources, it's often a very large hurdle for the programs and particularly the contractors to get good data and then to clean it up and make it actionable. Picture this, we've been operating these contracts, implementing the technology, finally got the data, made it actionable, but each audit scenario before we can work needs to be approved. So unlike your typical contract where you have a defined scope and it's contiguous, what the operation would be, under both the Medicaid and Medicare RAC, before we can do any work, we have to submit scenarios. They go through a rather lengthy approval process, and each time we want to do another review, that process starts over again. So again, that one of the contractors' perspective is that it does take rather a long time to get any scenario approved. Other things that is an interesting thing on the state side for the Medicaid RAC program is that states don't always have the authority or willingness to do the corrections and recover. And I'll give you an example of this. We had one state whereby the findings were not disputed by the providers who were impacted by them. In fact, they agreed with them, but they questioned the authority of the Medicaid program to actually recover the amount. So again, the work was done over the course of over a year, and then the state didn't have the legislative authority to actually do any corrections. Medicaid RAC is impacted by Medicare RAC, and we often feel that shouldn't be the case. The programs are very different, and they need to be more localized. Also, in that regard, we've seen conflicting policies between federal and state regulations. So I'll give you an example, particularly on the Medicaid RAC side, where we'll see a federal regulation have a state exception to it. The state often wants us to follow the state exception, but the providers or other stakeholders may say, no, the federal rules apply here. We want to follow one type of program. And the contractor is kind of caught in the middle. And to be quite honest, we just want to do the right thing, and we want to have one set of rules to follow that's as black and white as it can be. And that's often a very difficult situation to navigate for us and for everyone involved. Also, I would say that the transparency and reporting, there is different levels going on, and we often feel that we don't have the same type of information coming out from different reporting entities. So I know that you all have seen the CMS reports on the Medicare RAC, then you see the RAC tracker reports and other types of reports, and you say, well, how could they be presenting the program so differently? Are appeals this amount or are appeals this amount? Is the program successful or is it not by these measurements? And we, as contractors, also find that frustrating. We wish that there was one set of truth for each of the programs, whether it's the Medicare RAC or the Medicaid RAC, that everyone can work towards, use to measure the success, and also use to find out where are the most important areas for improvement and changes to the program. And lastly, I will say, again, from our perspective as well, the appeals process needs some improvement. One of the frustrations for contractors, besides the fact of the backlog, is that since the ALJ is an independent body, they don't follow the Medicare regs as strictly as we are told to, or as the quicks are told to. So that often becomes a conflict, because we want to, again, be fair, do the right thing, but then we see decisions being made at the ALJ level that don't seem to be following the policy strictly that we were told to follow. So that's a point of frustration, I think, for many stakeholders involved. Having said that, I think there is some common ground here, particularly for the providers and the contractors, but for all stakeholders. And I'd say, first and foremost, the Medicaid and Medicare programs need to be sustainable. I think we all agree to that. With the demographic shifts in our country, with the implementation of the ACA, both of these programs now become much more important, and we need them there for those who truly need them. So the programs have to run efficiently. They have to maintain fiscal sustainability for as long as possible, and I think we all agree to that. Second thing we all agree to is that true bad actors have to get out of the system. So those, we should not be paying for services that were never delivered, or worse yet, that were purposefully inappropriately delivered that can harm people and also cause the program money. So we want to make sure there's focus in this particular area, that there is no waste going to fraud schemes or other scenarios that don't send dollars to legitimate Medicare and Medicaid providers. The improper payment rate, I think we all want it to improve, both underpayments and overpayments. We want that efficiency. And although the program is touted as a success, the Medicare RAC program at $7 billion corrected, we all agree that process improvements are needed here to make it better for all stakeholders. Increased transparency and education from the standpoint of everything from when guidance is released, and I would think the big topic for many of today's sessions is the 2 midnight rule. When there's sub-regulatory guidance issued, that should be more clear. It should be articulated well. It should be put out well with discussions as well as information where all the stakeholders can view it, understand it, ask questions, and really be able to proceed in a manner where there's not confusion, there's not concern that it's going to change the next day or the next week and have multiple changes on the same rule. That needs to change, as well as I think from the operational perspective, we would like to see more transparency in the information that's exchanged from RACs to providers as well as CMS. And then the appeals process, we keep saying it, but it's important to mention. And then also I think many people would like to see a standard set of reporting so we can all be working from the same playbook. So with that, I'll leave you with some of the contractor perspective recommendations. And I would say first, we'd like to see improved transparency through technology and communication. I mentioned the communication on the guidance and how that might have to change, but technology can be improved, particularly for the Medicare RAC contract. And I'll give you an example. For the Medicaid RACs, some states have implemented what's called a provider portal, where the Medicaid RACs issue real-time claims review information through a secure web portal. The providers can go on, see what claims are being reviewed, why they're being reviewed, what's the status, et cetera. That's a really good advancement for a variety of reasons. It's a great communication tool. There's no concern about having to reach a call center during certain hours. It's available 24/7. Don't have to worry about time frames, et cetera. It gives hospitals that have systems where they might have a local or remote hospital access to what's being audited for that particular hospital without have to going through paperwork or having paper documents shuffled from one location to another. It's a really big advancement. The Medicaid RACs, many of them are using them. It could be utilized for Medicare RAC. Likewise, facilitate more use of electronic data. So besides this provider portal type of arrangement, any type of demand letter or correspondence can also be issued electronically and securely. There's technology that exists for that now. Health plans will use it. Many other healthcare entities will use these. We can use them with the RAC program to make everything more efficient, particularly, again, where we have hospital systems that manage multiple locations and don't want to keep track of paper documents going to remote locations. We talked about CMS policymakers, but I want to emphasize, I really think it calls for an engagement of all stakeholders, particularly the providers and the contractors, in terms of the impact of regulatory guidance changes and what might be some of the result or backlash before something is put into place. So I think that those dialogues have to be during the development of the regulatory process, but also, again, after the regulation has been determined during the rollout. Appeals process, we certainly would like to see more resources and workflow management for the ALJ process. We'd also like to see a more standard set of how decisions are ultimately being determined so that we're all working from the same playbook. Define responsibilities for audit and claim processing. So what we run into as a contractor, as I mentioned, is there are many different entities doing reviews. The MACs are out there, the ZPICs are out there, the different state-level agencies or federal OIG and other agencies out there. We would like to see very strongly and definitively defined roles and sort of parameters for each of these programs so there is an overlap in them. And then, again, as I mentioned, we still see discrepancies between federal and state regs, so we'd like a formal process on how to deal with that so that everyone is aware of an escalation and there is an arbiter on who makes the final determination in these cases. And lastly, again, I think a formal standardized reporting result package on the Medicare RAC program and then eventually the Medicaid RAC program will be useful for all of us stakeholders. So again, we can focus on what's been successful, we can make sure that we're bringing more education to the forefront, and then we can correct what hasn't gone so well. So I left some time for questions here, but I just want to leave you with the thought that I do believe strongly that common ground exists for the RAC stakeholders. We all want these programs to be sustainable, and we all have to make sure that to be sustainable and to have their fiscal resources, that there is no waste in the system, so that whatever we can do either on the front end through education or on the back end through a more efficient recovery audit process, I think there's opportunity for us to work together to identify those things and get them in place and have working sessions with CMS and other administrative bodies to help make that happen. And we do agree that programs can be improved, and I want to say from the contractor perspective, we do want to work with you all to make that happen. Thank you very much for your time. I appreciate it.